So my interest in this area started relatively recently, a couple of years ago. And I was I run across a couple of articles about, the potential use of psychedelics as therapeutic agents. And I was actually having lunch with a friend of mine that day. It's a guy I've known for probably 15 years. He just asked what was up, and he's actually a representative for a pharma company. He's not a physician, and I said, yeah. So I just come across a couple of articles about the potential use of psychedelics, of things like magic mushrooms and LSD as potential treatment options for like treatment refractory patients. And he gets this funny look on his face, and he says, Chris, if you were to ask me the most important day of my life, I should tell you that it was the day I got married or the day that my first child was born. He said, but it was the day that I did LSD. And I was so struck by that. And so he tells me the story about how when he was in college, finishing up their college career, he was out with some friends, and one of them had gotten some LSD and brought it along. And they went out to the woods near campus, and they all took it. They'd never done anything like that before. And he goes on to tell me about just the most amazing day he's had in his life, and just about the way he found himself thinking about himself and his relationships, and how he spent about 3 or 4 hours just lost in the wood grain of the picnic table he was sitting at, and just this amazing sense of connection to other people and other things. And it was just blew me away hearing about his experience. I was like, wow, like that's amazing. Like, so how many times have you done it since then? He said, that's the only time I've ever done it. And over the next probably 3 to 6 months, I started having this conversation with other people that I knew, and I was surprised how many times I heard a very similar story about how this just unbelievably mind-altering substance that seemed so profound for people, yet it wasn't like they were going back to do it all the time. And that was fascinating to me. Again, the whole notion of addictions and of substances. I mean, I sort of get why we like the things that we generally like. I get why people like opiates and benzos and THC and alcohol, and I understand what goes on in tickling in the brain that creates that effect. But this was so interesting to me to think about a substance that created such a profound experience, where people weren't necessarily going out to do it over and over and over and over again. So that's really what triggered my interest in this topic in general. And I would recommend to anybody who's interested a great book that I read early on by Michael Pollan called How to Change Your Mind. And basically, he's this investigative journalist, author essentially, who really throws himself into whatever story he's working on. And he spent a couple of years researching this, and then also dabbling with a number of these substances himself, as well as talking to some of the researchers around the world doing really cutting-edge research on this. So it's a great primer for this topic if you're looking for a nice 10,000-foot overview. How to Change Your Mind by Michael Pollan. There's also like innumerable interviews with him on YouTube that you can find as well. So this is not new stuff. There's archaeologic evidence of mankind's involvement with various types of psychedelics going back maybe as far as 10,000 years, and there's literature, there's evidence in the historical record going back maybe 4 or 5,000 years about mankind's involvement with these substances. And these are typically used in religious or spiritual ways, medicinal ways, recreational ways. And one of the things that's really interesting, as you look at all of these accounts, really regardless of what culture they came from, is this issue of sort of there being something sacrosanct about this. That you don't see reports of these kinds of substances being used cavalierly or being used recreationally. And really interesting, across most cultures, this has always been done with a fair amount of reverence. There's oftentimes this is seen as something of great learning. This is something that people do when they reach a certain age. In ancient Greece, they would use psychedelics. It was just 1 day a year, and there were profound sort of societal taboos against you were a horrible person if you ever deigned to try to use these things at other times. So it's interesting that this substance, which people have been so interested in for so long, and find so special in so ways, largely hasn't become something that people just go out and abuse, for lack of a better term. So there's different ways of categorizing the psychedelics, and people argue which things should be included based on either phenomenological effects that are experienced when you use these things, or if we just try to look at the chemistry involved. But sort of to give you a 10,000-foot view, psilocybin-containing mushrooms, magic mushrooms, peyote or mescaline, dimethyltryptamine, DMT, ayahuasca, Ibogaine, LSD, and then MDMA is sometimes included with the psychedelics. Pharmacologically, it doesn't look sort of like the other psychedelics do, but it creates a very similar set of experiential effects. So we'll talk about that just briefly. So ayahuasca is an interesting compound. This is actually typically created as a tea that's brewed from two different plants. One plant is a plant that contains a very high level of DMT. Now, among the psychedelics, DMT is probably one of the most powerful ones in terms of how quickly it hits you. So when people use DMT in certain other forms, it's a really rapid dissociative experience. People will hallucinate. It's just incredibly intense, but it lasts for 15 minutes and then it's done. So with ayahuasca, what they do is they use a plant that contains a high amount of DMT with another plant that's a monoamine oxidase inhibitor. You know, those things that they tell you don't mix anything else with this. And the reason they do that is the monoamine oxidase inhibitor keeps the serotonergic functioning of the DMT going long enough for this to have a really lasting effect. So this is usually done, and again, this we've got documentation going back for as far as 1000 AD. Now, you describe this to people, and people say, "Why in the world would anybody do this?" Right? Because when people use this, they get extraordinarily sick. Thanks. They puke themselves. They poop themselves for hours on end sometimes. Yet to a person who I've spoken to, they all consider that to be like a small price to pay. And weirdly, it sort of becomes part of the ritual, part of the cleansing aspect of this. So ayahuasca has been used by people frequently dealing with trauma. A lot of experiences that people have had, people with refractory PTSD, people that have had refractory problems with depression or anxiety. And they really describe this sort of life-changing experience. And sometimes people will go on these retreats where they might do ayahuasca 2 or 3 or 4 days in a row. But if you see video of it or you listen to them talk about it, you're like, why in the world would you do that yourself? You're literally writhing on the ground, vomiting and rolling around in your own feces sometimes. So certainly an interesting compound, and it's making its way into popular culture a lot. You hear more and more about this. LSD, one of the granddaddies here. So LSD is sort of an interesting history. This was discovered initially in 1938 by Albert Hofmann. He was a Swiss scientist working for Sandoz. And at the time, he was researching medicinal plants. And they were looking at fungus rot, or fungus ergotamine derivatives that would be potential compounds that might be either respiratory or circulatory stimulants. So it was one of the many compounds he synthesized, sort of set it aside for 5 years, and then he resynthesized it in 1945 and accidentally exposed himself. So he had a few grains apparently on his fingertip and put his finger in his mouth. And he wrote down what happened following. He said, "I was affected by a remarkable restlessness combined with a slight dizziness. At home, I lay down and sank into a not unpleasant, intoxicated-like condition characterized by extremely stimulated imagination. In a dreamlike state with eyes closed, I found the daylight to be unpleasantly glaring. I perceived an uninterrupted stream of fantastic pictures, extraordinary shapes with intense kaleidoscope play of colors. After some 2 hours, this condition faded away." So it was after he was home and he had this experience, he figured out, holy cow, I must have gotten into something at the lab. I have to go back and figure out what it was. So 3 days later, after his accidental exposure, he went back and took a purposeful exposure. So he took a pretty solid dose, 250 milligrams, and a typical dose is maybe 100 milligrams, maybe 200 milligrams. And then he realized as he's sitting there at his lab, holy cow, I don't know if I want to recreate that experience I had a few days ago here in the lab. I better get myself home. So being the good Swiss scientist he was, he has a bike and he gets on his bike and he rides home and he starts to have his second trip while he was riding his bike on the way home. So now every year across the world, April 19th is celebrated as Bicycle Day, which marks the sort of the purposeful first use or discovery of LSD. So how does this work? Like all of our classic psychedelics, LSD functions really primarily as a 5-HT2A agonist. A little bit of argument in the literature, might some of these substances have partial agonist effect, maybe, but the main thing that they do is that they pound on the 5-HT2 receptor. And keep in mind, when most of our involvement with the 5-HT2 receptors in psychiatry involves blocking it, right? All of our atypical antipsychotics work by blocking dopamine type 2 receptors, sometimes other dopamine receptors, and specifically 5-HT2 receptors. We either block it or we have a partial agonist effect on 5-HT. So this is essentially in some ways doing the exact opposite of what we do with an antipsychotic, which is one of the reasons that people who should be especially careful of using these types of substances are those folks who have psychotic disorders, those people with schizophrenia, or people with bipolar disorder, because you are essentially putting them on an antipsychotic. That's one of the reasons that these medicines were also referred to as psychomimetics, that they could induce or mimic the effect of a psychosis. So LSD has a long half-life, about 8 or 9 hours. The effects last for anywhere from 10 to 12 hours subjectively. Threshold effects are usually seen around 10 to 25 micrograms, recreationally or using it for some purpose. Again, anywhere from 40 maybe to 500 micrograms, which is about a tenth the size of a grain of sand. So this is powerful stuff. Literally 5 or 6 kilograms of LSD would be enough to dose every adult in the country almost. Psilocybin is probably one of the other better recognized psychedelics. And this psilocybin or magic mushrooms had been used by indigenous people of Central America as part of a cultural or religious tradition. It was referred to as the flesh of the gods by the Aztecs. And this was in fairly regular use up until the time of the Spanish conquest, when its use was really driven underground by the Catholic Church. And so you would see people using these, indigenous people using this, but not a lot of other outside use. And really what led to the sort of rediscovery of this by the West was in 1955, Gordon Wasson, who was a banker from Manhattan and just like somebody who had this interesting hobby of mycology, he was just interested in mushrooms. He heard about these magic mushrooms. So he goes to Mexico and spends a fair amount of time there talking to people, being introduced to people that let him experience the effects of these magic mushrooms, these psilocybin mushrooms. And 2 years later, he published his stories under the title of Mushrooms That Cause Strange Visions in Life magazine. And that's when it really sort of caught the attention of more people in the country. So in 1957, a couple of years later, an expedition was launched. They said, we're going to go try to do some science here, right? We're going to collect these mushrooms. So they did. They went and they collected them, and they sent them to who? The father of psychedelics, Albert Hofmann, of course, back at Sandoz. So he synthesized a number of chemically related compounds and said, you know what? Yeah, this is what's going on. It appears to have a very similar effect to what we saw with LSD. And in fact, they developed this form of psycholytic therapy. So they identified this. It was basically psilocybin and psilocin are the two primary compounds. And psilocybin was marketed for a long time under the name of indocybin. And this was used around the world. This was used more extensively probably in Europe. But there were clinics where you could go and have essentially psychedelic-assisted therapy. And And then this caught on in the U.S. also, sort of in the 40s and 50s. So it wasn't uncommon for people to use this at home. It was sort of seen as the intelligentsia would use this. So people in the arts, academics would get together and have these experiences using LSD. And throughout this time and throughout its clinical use back then, there were no reported serious adverse events. And since the resurgence of some research, starting around the 90s and moving forward, during that time, as we've kept a little bit better data, there have been over 1,000 individuals who've been exposed without any serious adverse events, at least physiologically. So what changed everything? Well, our friend Timothy Leary. Timothy Leary was a psychologist at Harvard who was very interested in psychedelics. And he was eventually fired from Harvard in '63 because there were allegations that he was experimenting on students, sometimes with their consent and knowledge, but maybe sometimes not. And he was sort of participating in the experiments himself. So they had questions about the validity of some of the studies. But he was a very controversial figure. He was the person that coined the phrase, turn on, tune in, drop out. And keep in mind the context at the time. So this is in the 60s, right? So there was a huge concern among parts of society that if we have all these, hippies, if we have all these love children going out and using LSD, they're going to drop out of school, and they sure as hell aren't going to want to be drafted to go fight in Vietnam. So the government sees the writing on the wall, and they decide we've got to change something here. So Richard Nixon referred to him at one point as the most dangerous man in America, and he had this whole wild history where he took off, fled the country, was in different countries before I think he was eventually arrested. But the psychedelic counterculture really grew in the 1960s up until the time that the Senate made LSD and other psychedelics illegal. So at that point, that's when most all the research had stopped. DMT, one of the active ingredients in the ayahuasca, found in many plants and animals, but role in physiology is unclear. It has some immunomodulatory effects, apparently. Where this is obtained frequently is the Sonoran desert toad, and it was weird. Whoever discovered this, right? What are people doing out there in the desert? The Colorado river toad or the Sonoran desert toad has DMT and glands in its skin as part of its defense mechanism. So when they're threatened or hurt, they release this milky white venom from their skin. So people will go out and get these toads and squeeze them or scare them. They express this milky white substance, and they collect it on a glass or a piece of a mirror or something. Let it dry. It dries into this brown powder, and then you smoke it. And when you smoke it, again, you get this almost instantaneous, extraordinary psychedelic trip that's very time limited, like lasts pretty reliably 10 to 15 minutes, and that's it. There's also a variant form of this, 5-methoxy DMT, that has sort of apparently experientially different effects. So one of them, like with DMT, this is the one where people say, I met aliens. There was a strong sense of agency that I was in the presence of someone else. I was in the presence of some other thinking being. It wasn't human. It may have been an angel, an alien, something, but a distinct feeling of being in the presence of something other than yourself. Whereas the 5-methoxy DMT tends to make people just more. It sort of kills your ego. It basically takes the I out of everything for you. Ibogaine is something we don't see as much of here, more in South America, naturally occurring psychedelic found in a plant. Not well studied or approved. It's been studied in Brazil as a treatment for alcohol addiction. There have been 19 fatalities reported since 1990 up through 2008 in patients who had been treated other places. Again, not great records. We're not sure if it was causal or not, but some of these patients died of heart failure or cardiopulmonary arrest. It can cause initially sort of like that visionary phase like we talk about with psychedelics, followed by this introspective kind of phase of just that ego dissolution. And this also serves as a potent SSRI. It's a moderate K opioid agonist, a weak mu opioid agonist, or partial agonist. And then mescaline, of course, found in peyote, a small spineless cactus. It's also seen in, you also find the same chemical or a very similar chemical in San Pedro or Peruvian torch. This is another of the psychedelic alkaloids. Again, used for over 5,000 years by Native Americans in Mexico. It also is a very potent 5-HT2A agonist. Its effects can last 10 to 12 hours. Mescaline can sometimes cause a little bit of tachycardia, though. And then MDMA, 3,4-methylene dioxymethamphetamine. So this was initially developed by Merck Pharmaceuticals back in 1912 when they were looking for a compound to stop abnormal bleeding, right? Serendipity reigns supreme. So different pharmacology than most of the psychedelics, but it's grouped with them sometimes because it has some similar effects on people subjectively. So the subjective effects are to dramatically reduce fear and increase the feelings of empathy, closeness, love. Everybody becomes your best friend. Deaths have occurred when using it alone or in combination with SSRIs or with monoamine oxidase inhibitors. So of the psychedelic-like substances, this is one that is potentially more dangerous. It reaches a maximum concentration in 1.5 to 3 hours, and its duration is about 4 to 6 hours. Now, following the use, this significantly depletes serotonin stores. So it's not uncommon after people have used MDMA or used ecstasy or mollies that they can go into a profound depression. And I've heard people who have used this talk about, hey, listen, I've never had significant depression in my life. I've never really felt this way, but I felt suicidal after I used this. They still felt like it was worth it. And apparently that effect might be able to be blocked if you load yourself up with some additional 5-hydroxytryptamine before you use it. But this is apparently just like an extraordinarily, it's like empathy city, right? People just feel incredibly close and trusting and open. And that's one of the reasons it's been used therapeutically in the setting of like an MDA-assisted therapy. And again, acts presynaptically to cause the release of serotonin, norepinephrine, and dopamine. It's also a substrate of serotonin, norepinephrine, and dopamine transporters, and it serves as a VMAT2 inhibitor. So it sort of depletes serotonin, norepinephrine, and dopamine, pushes that out from the vesicles into the cell, and then also can cause it to just dump out into the synapse. So it's like that's one of the ways in which it's sort of like an amphetamine. It has some other chemical effects that we're less familiar with. It has a preference for serotonin over other catecholamines, and has some other various effects. The research on this, the Multidisciplinary Association for Psychedelic Studies, MAPS, is funding a pilot study using this to treat PTSD. And actually back in November 2016, the FDA approved a large-scale phase 3 trial for clinical use in PTSD patients who hadn't responded to other therapies. So the potential therapeutic uses here. So again, what makes a psychedelic is primarily this action of being a strong 5-HT2 receptor agonist or partial agonist. And 5-HT receptors are fairly ubiquitous throughout the brain. This is one of the trials done in 2016. So this was an open label feasibility study. They looked at 6 men and 6 women, so just 12 patients who had moderate to severe treatment refractory depression. And they gave them either psilocybin 10 milligrams was their first exposure, and then 7 days later, a dose of 25 milligrams in a supportive setting. And so these are pretty, good. These are pretty solid doses of psilocybin. And then they looked at symptoms using the quick inventory of depression symptoms from week 1 to 3. And what they found was that depressive symptoms improved really strikingly, right? So at 1 week, the change in their QID score was 11.8, highly statistically significant. And even going out 3 months, keep in mind, with just 2 exposures, 2 guided trips separated by a week, still highly statistically significant 3 months later. They also looked at this in a double-blind placebo-controlled or a double-blind crossover study for PTSD, and these were among military veterans, firefighters, police officers, other first responders. And again, they had just 2 limited exposures, and they looked at doses of 30, which was meant to be almost like an active comparator kind of dose, 75 or 125 milligrams, just in 2 8-hour sessions with psychotherapy during the time that you were tripping, separated by a week. And if you look at the change in the CAP scores, the clinician-administered PTSD scale scores, look at the improvement there at the 75 and the 200 and the 125 milligram. So dropping your CAP-4 score 58.3 points or 44.3 points. What other psychoactive medicines do we have that put up an effect size like that of 1.1 or 2.8? That's the kind of effect size you see with, again, benzos, stimulants. And perhaps even more interesting, again, after 2 guided therapies under the influence of MDMA, at the 12-month follow-up, they maintain this benefit. So their baseline CAP scale scores at the beginning of the study were 87.1, and even at the end of 12 months, the average score was 38.8. And that's one of the things that's really interesting about these compounds. It really is very different than our normal approach with pharmacology, right? It's like, take this medicine, you're going to be taking it every day for the next year or 3 years or the rest of your life. These are compounds with tremendous durability, apparently, right? With minimal exposure, with a very limited number of exposures that seem to maintain this benefit over time. And you see that in study across different psychedelics and also across different disease states. If you go to clinicaltrials.gov and just sort of do a quick search on different ongoing psychedelic studies, these are the areas that's being looked at in depression, OCD, body dysmorphic disorder, anxiety, some smaller use in migraine, cluster headaches, smoking cessation, cocaine use, alcohol dependence, LSD, illness-related anxiety disorders, anxiety, severe somatic disease. What I said in my earlier talk about if you're complementary or alternative treatments, one of my criteria is the old first do no harm, right? So if we're going to use something that we don't have a lot of good data, as much data as we'd like, it's better to use things that are safe, not harmful, well tolerated, and hopefully not horribly expensive. Well, the good news is, at least from a physiologic standpoint, you are hard pressed to find a safer class of substances than psychedelics. In fact, probably the only thing that may be safer than LSD or psilocybin physically is marijuana. But this is sort of a nice graphic showing basically the therapeutic index, the ratio between a fatal dose and an effective dose. So beyond the chemistry, what happens physiologically in the brain when people take these substances? So a lot of it has to do with this construct called the default mode network. And this is something, at least when I was in training, we really didn't have this concept. We didn't talk about this collection of brain circuitry in this way. So this was newer to me. But the default mode network is comprised of the medial prefrontal cortex, the posterior cingulate cortex, and the angular gyrus. So what? What do those areas of the brain seem to do? Well, again, it's always hard to make these structure function kind of claims. But what appears to be the case is that the medial prefrontal cortex is involved in decision making, working memory, access and retrieval of long-term memories. It may help people learn the associations between, given a certain context or given a certain event, what is my anticipated emotional response to that likely to be? May also be involved in sort of social cognition, how we read other people. Posterior cingulate cortex is involved in self-referential thinking. So this may sort of be the heart of the ego, right? This is what makes I. This is what makes me, whether that's a real me or whether that's some neuroscientists would argue is an illusion. But it connects the prefrontal cortex, sort of the planning and executive functioning area of your brain, with the hippocampus, with memory processing and emotional processing. So it's theorized to link our thoughts and actions with our sense of who we are as people, right? So this is where we come up with the gut check. Oh, that's okay. That's not okay. This is what my belief system is. These are what my ethics are, and how do I resolve that with what I see going on or what I'm thinking about doing? And then finally, the angular gyrus involved in a number of language processes, number processing, spatial recognition or spatial cognition, memory retrieval, attention, theory of mind. This idea that you aren't just robots out there. You all have brains. You're all your own conscious entities out there. So you can almost think of this as a conductor for the brain's orchestra of different functional units, right? So it exerts this top-down control over all these other things that are going on in our amazing brains: visual processing, motor activity, mood, memory. And you can sort of think of the DMN again as sort of as the structural basis of the ego or the sense of self. It serves to sort of surveil the internal milieu and say, hey, what's going on with me? Am I okay? It's sometimes described as the area of the brain that becomes deactivated when we're busy doing other things. So the default mode network is deactivated if I ask you to take out a pencil and paper and do a math problem. But if you're sitting around at the end of the day, if you're sitting on your porch looking out over the pond, sort of thinking about your past, if you're reminiscing, if you're thinking about the future, that's when we see the default mode network activity level really change. And one of the things that we know is that psychedelic drugs incredibly diminish the level of activity within the default mode network, and that tends to increase the entropy of the system. So I like to think of it this way. We sometimes talk about our brains as computers, but they're not. They're analog devices. I can't upgrade my brain. It's not like my computer. I can't shove more core processors into it. I got one processor. So how do I make that more efficient? Well, since I can't put more processors into it, I can do what we used to do with our old computers. I can overclock it. I can try to run it faster. Or I can try to find a fix with firmware or software. I can build macros. I can offload responsibilities so I don't have to consume so much of my processor's work. So I'll come up with quick keys or macros or shortcuts. And that's sort of what our brain does largely. So our brain, as we develop and mature, we come up with this network of highways. And it's like, I don't want all that mess. It's like I'm out walking the same trail every day. I'm going to wear a rut in it eventually. And if I'm sort of close to that, it's just easier to walk there. It might be interesting if I walked over here, but man, it's just easier. This is my default mode. And so the brain has a relatively lower state of entropy, more highly organized, and most of the traffic is going on superhighways. That's probably functional. It can go too far. If you look at the activity of the default mode network, it's overactive in conditions like depression, especially overactive in OCD, in anxiety states. And in fact, if you look at people who are depressed versus who are not depressed, and if you look at them through functional neuroimaging, where you're correcting the data, you find that people with depression or OCD or anxiety have higher levels of activity and even more of a low entropy state. Same thing with people with addictions, right? Now, if somebody's depressed and they're sitting at home, that's one thing. When they go to work and they get involved in doing something, that entropy increases a little bit, but not as much as it does in non-depressed people. So it's almost like your ability to chill is negatively influenced by the state of being depressed or having OCD or having anxiety. Now, there are some states where there's very low DMN activity, high entropy states of the brain. So we're not working with our superhighway system. It's like, hey, let's go explore all those, just like John Denver said, country road, take me home. So you see this really high entropy state. Now you see these high entropy states other places. You see that in young children before they've worn ruts in their brain. You see it in people who tend to be involved in more creative thinking. You can unfortunately see it in early psychosis. People with psychotic disorders have a much easier time paying attention to a lot of different things, but sometimes too much time paying attention to other things, and they lack the ability to sort of assign some valence to it or to assign some importance to it. So you have to be careful here. But the other group of patients who display this really low DMN activity or high entropy states are people on psychedelics. In fact, researchers looking at people that are highly skilled meditators. So if you take somebody who's had like 20, 30,000 hours of meditative practice under their belt, if you look at members of religious order that may have 20 or 30,000 hours of contemplative prayer or some other sort of contemplative practice under their belt, and you put them in an fMRI, and you tell them to engage in their meditation or in their prayer, what do you see? You see the DMN activity drop like a rock. It's the exact same thing you'd see in somebody who's never meditated or prayed when you give them a psychedelic, into largely the same extent. In fact, in the book Michael Pollan wrote, he was talking to this researcher who'd been involved in this. And so they say, okay, we're going to put you in the scanner. Here's your DMN activity at baseline. Boom. Take it out of the scanner. Now we want you to do this breathing exercise, this relaxation training, this meditative practice. Put them back in. Look, you've been able to suppress your DMN activity. Oh, that's interesting. So he gets back out of the scanner. And he says, can I go in one more time? They're like, yeah. He said, I want to try something. So he goes in, and they put him in the scanner, and the people that are looking at the data, filter through, they're like, holy crap, what did you do? Because it had dropped far more significantly than with the exercises they had given him. And he said, I remembered my first mushroom trip. Just the memory of it engendered that kind of physiologic difference. So good reason to think from, again, early and emerging research that it is this suppression of the DMN that seems to be associated with the effect of these substances. Number of studies going on right now. Even though this is not an FDA-approved treatment, they have cleared it for study. So various places, academic centers around the country are studying this. So obsessive compulsive disorder, looking at it for things like depression, looking at it for alcohol dependence, tobacco dependence, some really interesting data there, treatment-resistant depression, existential distress, people that get these horrible cancer diagnoses and they're living in a sustained 24-hour-a-day panic attack. They've used it there with great impact. Compass Pathways is a company out of the UK that is supporting a lot of this research. Got an advisory board that includes past FDA or past APA presidents, past National Institute of Drug Abuse chairman. Johns Hopkins last year had opened a privately funded Center for Psychedelic and Consciousness Research. Some donors put together $17 million to try to, again, take a more science-based approach to learning more about these substances and about their potential use. It's an interesting pilot study on smoking cessation done at Hopkins. So the best treatments we have right now for smoking cessation is probably behavioral therapy plus Chantix, varicenoline. There's other things that have been used, but that's what the data probably looks best for. And best means that at 6 months, abstinence rates are somewhere between 2 and 25%, 2 and 24%. So this is a study where they looked at 2 sessions of psychedelic-assisted therapy, again, separated by a week, and the abstinence rates confirmed by lab. So they weren't just asking patients, they were doing laboratory measurements to assess use of nicotine. 80% of patients had abstained. Yeah, over triples the best thing we have now. Very similar pilot studies that have been done in depression, looking at people who've had treatment-refractory depression, 2 exposures to psilocybin, and again, the 6-month data in terms of those patients who were not just better, but those patients who are in remission, about 68%. The USONA Institute opened up a few years ago. This is a sort of a research center affiliated, I think, with the University of Wisconsin. It's run by Charles Raison. He's a internationally known psychiatrist, researcher. He's had a long-standing interest in this, and they're actually doing the FDA study on psilocybin. So they're going to look at this in treatment-refractory depression in like 7 centers around the country. Great website if you have interest in this. They consolidate a bunch of information. They're curating a lot of information on these types of studies. So it's a good source if you're interested in this topic. One of the things that was also, I was listening to an interview with Roland Griffiths, who's the director of the new Hopkins study that opened up. And the other thing that he said that I thought was really interesting was he said that as they've done these surveys in people who had experience with these substances, upwards of 80% of people rate it as one of the most meaningful things that they've done in their life. Back in the day, back in Timothy Leary's time, there was this famous experiment that was done called the Good Friday experiment, where they went out and they got like 20 people that were in divinity school. And they broke them in half. Half of them they gave high-dose niacin just sort of as an active comparator to make them feel a little weird and spaced out and flushed. And the other half they gave them, I think it was psilocybin. And the people to whom they gave psilocybin all described this amazing sort of transcendent spiritual experience that they had. If that was sort of their organization, obviously, as people that were in divinity school. But the really interesting thing was they went back 25 years later and tracked those guys down. I say guys because I think at the time I think they were all guys. And most of these people were priests at this point. And they asked them if they remembered their experience. And something like 75% of them at that point, 25 years later, still said, it's probably the most important thing I've ever done. So I think this is going to be, I'm at least midway through my career, if not past midway, so I'm always looking for the next best thing. And I have to tell you, as much as I try to guard my enthusiasm about things, I really think that this has the potential to be maybe one of the most important developments we see in psychopharmacology. I mean, I can't think of any other class of agent where you see these types of effects. And it's early, it's preliminary, so we have to take this all with a big grain of salt. But I do think it's something that's going to bear paying attention to over the next 5 to 10 years. And there's fast tracking for some of these substances. So we may have MDMA approval for PTSD. That could theoretically happen in the next 2 to 3 years. And with psilocybin, who knows? But I think it's going to be an interesting treatment option for a lot of our patients who haven't been able to be helped by more traditional treatments. So with that, I'll close and thank everybody for their attention. Certainly. Yeah, so the issue of microdosing refers to taking very small, really sort of subclinical doses of these substances. So LSD, like a typical person, if they're going to get a typical trip, they might take 50, 100, 200 milligrams. People might microdose LSD with 100 milligrams, or with psilocybin, instead of in the studies where they were doing 10 to 25 milligrams, people might do like 1 milligram. So doses where, I'm sorry, micrograms, thank you. Don't do milligrams, that would be way too much. But people are doing this, and there's a lot of interest in their use for depression, anxiety, pain. People have also been doing similar things, microdosing like ketamine. And there is a rationale behind this. This isn't homeopathy. We're not talking about those kind of dilutions. And one of the reasons that these things may have such profound effects and such lasting effects is these substances have a huge impact on neuroplasticity. You can look at, so we've known this for a while about ketamine. You give people a single exposure of ketamine, and you can demonstrate neuronal budding, and you can see changes in the level of things like brain-derived neurotrophic factor, or cyclic element response, or cyclic AMP responsive element binding proteins. These substances are like brain fertilizers. And as impressive as ketamine is, it doesn't hold a candle to psilocybin, which doesn't hold a candle to LSD. With LSD, they've been able to demonstrate these, again, in as early as 24 hours, you can see these changes on electron micrography with picomolar concentrations of LSD. So this is really a fundamentally different type of pharmacology. So the whole issue of microdosing is going to be wildly hard to study because everybody's doing their own thing, and who knows how accurately people are doing this. But again, it's another area, and out on the coast, like out in Silicon Valley, this is just like a thing, right? They're convinced that it helps with creativity. There are certain tech companies where your initiation is you go away for a weekend with your team and you all drop acid or do mushrooms. And a lot of these people report microdosing and reporting it helping with things like creativity and their ability to think laterally. So again, there's a lot of interest out there, but it's I would tell people the plural of anecdote is anecdotes, not data.
And maybe the issue around how microdosing obviously doesn't create as much problem with the hallucinogenic effect and that type of thing, because that's been the big barrier in the past for approval, right? A high percentage of these patients, including with ketamine, will experience some kind of depersonalization or.
Yeah, so if you can get by with lower doses, and if you can slow down the absorption. So, for example, some people are looking at doing sublingual forms of ketamine at much lower doses, and you take the bioavailability down from nearly 100%, which it is IV, or even intranasally, where it's maybe 50 to 75%. But if you give it sublingually, the bioavailability is maybe 20-25%, and the Tmax is longer. And that really seems to dramatically reduce the risk of those kind of dissociative experiences. We don't know how much the dissociative experience is part of it. We don't know how much that's therapeutic. One of the studies that's being planned, which I think is really an interesting experimental design, is that they want to give people exposure to a psychedelic like to Psilocybin, but half of them they're also going to give them Versed to rob them of consciousness, to rob them of the memory of the experience, or maybe rob them of the ability to have sort of that phenomenological experience of the high, of the dissociation, to see how important is that? Is this just all pharmacology, or is there something about what the pharmacology causes to happen that's more important in terms of whatever potential therapeutic benefit there might be?